Thank you very much, Dr. Ahmed, for a nice introduction. Assalamu alaikum and good morning. So I'll be talking about the updates about the guidelines, but you know that in last 2 years we had got two big guidelines, one coming from the American Heart Association that was about 2 months back, and then another one was from the European Society of Cardiology late last year. So all these guidelines, huge number of pages are there. So what I thought is change my title to a takeaway. So at the end of the talk, we'll have 4 or 5 takeaway messages, which will be important. Now, 2025 AHA guidelines was endorsed by more than 13 organizations and associations, and while 2024 European Society of Cardiology guidelines, which are much more practical, you can see there were 15 new recommendations and 32 revised recommendations. I'm not going to talk about all the things, but at least once we know that blood pressure is a multifactorial, although we call it the primary hypertension or essential hypertension, but there's a huge interplay of multiple factors, which may be a genetic factors, okay, and which may be environmental factors, behavioral factors, individualized behavioral factors, and then we have got socioeconomic factors. At the end of the day, there's also a interplay of the systemic level also. So there is a renal mechanisms which cause blood pressure. There's a neural mechanisms which cause blood pressure. Then we have got a vascular mechanisms which contribute to the blood pressure. And then we have got other hormonal mechanisms like RAS and endothelial systems. So there's a huge interplay of all the things. The importance of these things is just to understand these things so that we can, change the medicines and treatment according to the available factors. Now, so first message is regarding the diagnosis numbers and requirements. As you all know that till 2023 we had different definitions. We had optimal blood pressure, we had a normal blood pressure, we had a high normal, then grade 1, 2 and 3. This was a 2023 European Society of guidelines. But latest guidelines, they have done away with all the things. So now we have got only 3 categories. There is a non-elevated blood pressure up to 120, and then there's an elevated blood pressure from 120 to 139, and then there's a category of hypertension. As far as the American system is concerned, they are still persistent with the same guidelines which they had before. So, categorization, they have got normal, they've got elevated, and stage 1 and stage 2 hypertension. Please note here that elevated blood pressure according to the AHA, even in 2025 guidelines, is from 120 to 130, while from the European guidelines, it is from 120 to 139. So this is a difference once one is noted down. Now, the guidelines also emphasize the importance of accurately measuring the blood pressure. It's very, very important to have optimal and standardized condition because the numbers matters here a lot. So therefore, we have to be 100% sure what you are diagnosing. So therefore, of course, you have to use a validated electronic cuff device. Patient has to be seated in quite comfortable room. You don't have to jump up the blood pressure check. So patient has to at least wait for 5 to 10 minutes. He should not be eating or drinking anything for last 30 minutes. And then, of course, even the doctors should know, or the nurses should not be talking to the patient while you're taking the blood pressure. Of course, patient has to be seated properly in comfort. So these are the small things because, I mentioned, nowadays we are so much obsessed with the numbers. So it is very, very important to be accurate at the time of diagnosis at least. Now, office blood pressure is same as I mentioned here, but there are 2 important things. One to remember that the first presentation or first time when you are checking the blood pressure, it should be checked in both arms. This is one thing which I mentioned. And then the arm, normally there's a 10 millimeter difference, so the highest arm has to be recorded. So every time the patient visits you, the blood pressure has to be checked in that arm. The second thing which is recommended is at least first time it has to be recorded, heart rate and rhythm has to be recorded to exclude dysrhythmias. And the third thing which they have reminded us is the checkup for the orthostatic hypertension at least for the first time. And then subsequently when the patient has got symptoms suggestive of orthostatic hypertension. This is very, very important to note down. Now the guidelines also recommend self-measurement and monitoring of the blood glucose. The reason is because it will help in achieving the better control, and self-measurement when properly performed also it will help in having a positive effect on the acceptance and diagnosis of hypertension. Patient will feel more empowered and involved in his management, and that will also improve the adherence to the guidelines, to the messages. And the guidelines also recommend the role of ambulatory blood pressure monitoring, especially sometimes in difficult patients when you want to differentiate between white coat hypertension and masked hypertension. or sometimes, it's morely there's a difficulty in controlling the blood pressure. So both for diagnosis as well as for the control, we can recommend the ambulatory blood pressure monitoring. Now, of course, there are the disadvantages, of course, because patient can wake up whole night because the blood pressure curve will be keep on inflating every 20 to 30 minutes. The home monitoring is also important, not perhaps for the diagnosis, but again for the proper monitoring of the control. It is a cheap, widely available, and you have to guide your patient, educate your patient at what times. Not nearly, we want 2 to 3 times blood pressure has to be checked up, maybe morning and evening times, or maybe 3 times. Okay, first reading has to be discarded, and the second and third reading, average of second and third reading has to be taken. So there are some disadvantages also, because you need a validated blood pressure curve at the same time. Now, please note here that I've talked about the home blood pressure and all the things, but if you, for the record purposes, the home and daytime or ambulatory blood pressure, they are 5 millimeter less cutoff as compared to the office recording. So whatever the category you are talking about, whether it's a non-elevated, elevated, or a hypertension. So 140 here and 135 here. Okay, that's it. The second thing which highlight our takeaway messages here is you need to assess a whole overall cardiovascular disease risk in the patient. Now we know that blood pressure, apart from along with the diabetes, dyslipidemia is a strong risk factor, and it is a start of the cardiovascular disease spectrum. Okay, and so therefore, and so this is one thing. So when you are facing the patient, so it's the first time at least, and it has got a target organ, or what we call the hypertension mediated organ damage, has to be looked for. Eye complications, heart complications, kidneys, what is in the brain, involvement of the arteries, so microcirculation. So this is various pathophysiological mechanisms and complications one has to look for. Now, these are established. If your patient has got established clinical cardiovascular disease, previous MI, angina, CKDs, diabetes, other evidence of the organ damage, or a familial hypercholesterolemia, these are the patients who have got already high risk. So therefore, this is a high risk patient. And the guidelines also mention that so you can calculate the risk, cardiovascular risk. Previously the Europeans were checking it through the score. Now they've given a score 2, and the score 2 is up for patients above 70. So these are the patients, these are the risk factors, you can check it. And for a diabetic patient, there is score 2 OPCVD. For American, they prescribe or they suggest this prevent score system. Every clinician should have this in their clinics also, where you not only check the blood pressure status, but there are different other parameters like smoking, diabetes. So you have to calculate the risk according to the presence or absence of these things. So this is a score which I was talking. This is available in the system guideline in the Google also, and then you can have it in the chart and show it to the patients also. So one thing is also, now one step ahead of the risk factors, while we talk about the risk modifiers. So you can classify or escalate the risk of the patient if there's these risk modifiers are present. In females, for example, history of gestation diabetes, gestation hypertension, preeclampsia, abortions, stillbirths, and similarly, people having from the higher risk ethnicity like South Asian people, it is family history of premature heart diseases, socioeconomic deprivation, SIL, HIV. So these are the conditions which enhance the cardiovascular risk. So therefore, you have to consider this while overall calculating the risk factors. Regarding the treatment decisions, the guidelines recommend that if there is an established cardiovascular disease, they are already categorized as a high-risk patient. So you can start the treatment even at the level of elevated blood pressure. For those patients who have got a elevated blood pressure, we are talking of up to 120 to 139, and a high cardiovascular risk factors, again, after 1 to 3 months of a lifestyle, you can straight away go for the treatment. And as I mentioned, if the blood pressure is elevated and the patient has got already established cardiovascular disease, then you have to start the treatment even at the 130. Now, lifestyle factors are very important. I don't have to spend time on this, but we all know these guidelines highlight again, recommend this importance of continuing to maintain, advise, and educate your patients regarding the guidelines. And we know the role of the diet in these things. Now, one thing here also, sometimes we tend to forget it. Now, if your patient is frail, you can calculate the clinical frailty scores are there. So any patient who has got a lifespan of less than 3 years or age is above 85 years or clinical frailty score is high, then you can lower down your target. Normally, you are going for a target control of 130 to 80 or 90, 85. But here, perhaps you can allow even 140 to 90. So this is very, very important for some high-risk patient. What is the algorithm for the treatment? Treatment is, of course, as I mentioned at the beginning, generally most of the patients will be requiring dual therapy at the beginning, except in those patients that I mentioned last slide, if the category is elevated without much risk, and then or if there's a referability there, or age is elderly. Otherwise, you can start patients with a with a combination low dose double combination therapy, calcium channel blockers with ARBs plus minus diuretics, and then after 1 to 3 months of a wait period, you can, if the targets are not achieved, you can increase to change to a low dose triple therapy. Okay, so low dose triple therapy, again you can wait for 1 to 3 months, and if the targets are not achieved, you can change it to maximize the dose of a triple therapy. And then perhaps later on you can add a fourth drug if you're thinking of it is refractory or resistant hypertension. Beta blockers, in last classification, they were given high value. Again, this time they have left it to the physician decision. They can be added at any stage of the treatment. Now, resistant hypertension, I don't have a time to discuss about the things, but again, as I mentioned, spironolactone is a fourth drug. If it doesn't work, then you can go for eplerenone also. And there's other lot of medications we know are available for the treatment as a fourth or fifth or sixth drugs: ACE inhibitor, direct inhibitor, calcium channel, alpha blockers, beta agent blockers, centrally acting drugs, vasodilators. The newer drugs are also coming. The guidelines do not mention about these things, but those things which I've highlighted in red, they have been now FDA approved. And especially there was I think last month there was about this Bredro state that is an aldosterone synthase inhibitor. It's a very potent drug for a resistant hypertension. So there may be place of these newer drugs which are coming now and recognized. Treatment adherence is very, very important. And when you talk of the adherence, this discussion has to be started even at the beginning, because problem of adherence may occur at the initiation when the patient does not initiate medication at all. You advise him, patient does not take it. Or problem of adherence may occur implementation. Patient says, yes, okay, I will take the medicine, but when he goes home, he doesn't take the medicine. Or sometimes he may stop the medication. So therefore, there are WHO also identified 5 areas of adherence, which may be socioeconomic factors. Of course, economy is important thing. Therapy-related factors. There are health system or insurance problems. Patients' belief, like condition-related factors, or polypharmacy is there, and some of the patient-related factors. Now, this is job of a physician to look into these factors, because very, very important to consider these while you are deciding the management. A multidisciplinary approach is also recommended. What they say is that when you talk of multidisciplinary, you of course talk of physicians, pharmacists, even nurse practitioners, physician assistants, dietitians, community health workers, other health professionals if the patient has got the complications. And here I will also include the family members. Please involve the family members in the discussion, because this is very, very important to improve their compliance. For a strategic approach, what we see there, again, we are talking of a pillar therapy in every, whether it's heart failure, whether there's others, stroke, these things. So adherence to the treatment guidelines is very, very important. And overcoming the inertia. When I talk of the inertia coming not only from the physicians, but from the patients. So we have to look and tackle those factors which are contributing to the inertia. Now we have living in the AI area, so through utilization of the new digital tools and novel anti-hypertensive agents have been considered. Multidisciplinary collaboration I already informed, and then you have to set appropriate goals according to the patient's cardiovascular status and risk factors. So lastly, learning points. Now our understanding, definitions, diagnostic thresholds, and management strategies have evolved over the period of the time. So we have to catch up with those changes. Now, changing thresholds, of course, have increased the prevalence and burden of hypertension. So are the challenges. The numbers are also very important. We talk about 130, 140, 120, whatever. So numbers, blood pressure has always been a number game. So therefore, they are very, very important. But they have to be considered in the context of a cardiovascular disease risk. Okay, then thing. Physician and patient clinician inertia, I've already talked about, is a significant barrier, okay? Then this digital technology, now we have got a telemonitoring of the blood pressure, availables, and even in the watch also. Therefore, these head devices will come up naturally, and then they have to be validated, and they have to be taken into account while discussing with the thing. And again, when you are taking with the treatment, please do not forget that social economic condition is very, very important. And when you are deciding about the treatment, always consider the socio-economic factors. Thank you very much.